All right, welcome back to the second part of this morning's conference. As I said, in the interest of time, we're going to go ahead and keep this running. And once again, thank you for being here with us today. It's with great pleasure that I had the opportunity to introduce a colleague, Dr. Reid Norman. Reid joined the faculty at Texas Tech School of Medicine and Health Science Center as a professor in 1983, where he continues today. He serves as the chair of the Department of Pharmacology and Neuroscience. Dr. Norman received his doctorate in philosophy and anatomy in 1971 at the University of Kansas Medical Center. He currently resides in Lubbock, Texas, and his wife, Dr. Cindy Jumper, is an internal medicine physician, and just this week was asked to become the chair of internal medicine there in the Department of Internal Medicine at our medical school. So without further ado, Dr. Reid Norman.
Oh, okay. Turn the mic on. We're going to review some of the information and questions regarding the general topic of neuroscience and some physiology. If you are like the students that we have, several years after you have neuroscience, you forgot most of it. So we're going to review some of the basic important things that are essential that you know for making a differential diagnosis and neurological problems. And one of the big things that in recent years that has appeared on these tests is imaging. So we'll review some of the imaging as we go along as well. A lot of imaging, particularly in the brain stem, that shows up vascular lesions. Initially, we're going to start here, just remind you a lot of neurological problems are developmental. Dr. Beal talked about that here, and I'm not going to go through much of the development, but just the terminology of some of the embryonic structures here and how they develop into, expand into the brain. The prosencephalon, mesencephalon, and rhomencephalon, well, the earliest stages after you have the neural tube, you have a 3-vesicle stage, and that develops into a 5-vesicle stage with the embryologic terminology: telencephalon, diencephalon, mesencephalon, metencephalon, and myencephalon. These terms are not in general use in the clinics except for the telencephalon and mesencephalon. But more commonly, we refer to the cerebral hemispheres: thalamus, hypothalamus, midbrain, pons, and medulla. The terms here that are more frequently. But occasionally on some of these USMLE tests, they use these terms that we use in embryology, so it's good to review those. And in addition to the actual structure of the brain, the neural tube it has components that are associated with various parts of the brain as well. The lateral ventricles here are primarily with the telencephalon, and this is where the greatest expansion of the brain is in the telencephalon in humans. And these bud off from the 3rd ventricle here, which is found in the diencephalon. And as you probably remember, the eyes develop from the diencephalon, are expansions of that. And we have some clinical situations that are associated with increased intracranial pressure all the way out to the optic cup. The cerebral aqueduct is the adult representation of the neural tube in the mesencephalon, and if you on an imaging scan, if you see the cerebral aqueduct, that little hole, you know that you're in the mesencephalon. That's a diagnostic of that. The fourth ventricle then is associated with the hindbrain, the pons, and the medulla. There are some typical questions that situations you should know here that are associated with neural tube deficits, spina bifida, anencephaly. These are the two most common. Hydrocephaly is really a problem with CSF circulation, and this largely can be corrected now in newborns. There are some environmental insults as well here, fetal alcohol syndrome being the most common, at least in the United States and Europe, that result in malformations of the central nervous system and mental retardation. There are some typical genetic defects here that you should review. The most common, as Dr. Beal and I guess Dr. Susie Graham talked about, Fragile X syndrome. This comes up, you've heard it 3 times now, so you should make sure you know that. But all of these here that are associated with the genetic, with a genome are ones you should review. I'm not going to spend hardly any time talking about neurotransmitters, but obviously they're very important. A lot of situations where there are substances in the environment which act on neurotransmitters or their receptors and cause problems. There are ways to manipulate abnormal levels of neurotransmitters involved in various neurological problems. There are ways to mimic those and to suppress them. We have a lot of drugs. I don't know if Dr. Tenner's talked to you, but he'll talk some about this in pharmacology. When there are neurotransmitter deficits, they can really result in certain neurological diseases. We have a lot of drugs, again, here that affect neurotransmitter levels. And besides these catecholamines and amines, there are literally hundreds of peptidergic neurotransmitters that are present in the central nervous system, and you should review those as well. Okay, the coverings of the brain and the ventricular system I'm not going to spend a lot of time on either, but these are important, particularly in blunt force trauma to the head, where you have different bleeding into the head, which can occupy space within a closed cavity. And when you have increased bleeding in the head, that tends to shove the brain out of the skull. And the place where that usually happens is out of the foramen magnum. And what is a part of the brain that is, when you have increased intracranial pressure, what is the part of the brain that tries to get out of the foramen magnum? Have you heard of tonsillar herniation, where the tonsils, the cerebellum, are right there next to the foramen magnum, and as they occupy that space, they compress the medulla. When you compress the medulla, you cut the blood supply off, and you inhibit cardiovascular and respiratory functions, and it can kill a person very quickly. So relieving this pressure can be an emergency situation when you have bleeding inside the head. Different types of hydrocephalus here that you should review. where and how to do a lumbar puncture. There are, and as well there's the blood-brain barrier is a protective mechanism, primarily a physical barrier that protects the brain from all that stuff we ingest that you don't want, that circulates in the blood, but you don't want your brain exposed to. However, there are windows in the blood-brain barrier, one of them very close to the dorsal motor nucleus of the vagus, so that, and this is called the emetic center here, that where you can monitor what's in the blood, and if you ingest poisonous substances, you can get rid of it by activating the emetic center. So these blood-brain barriers are very important, but the windows here too, and in the median eminence to monitor various substances and to regulate the endocrine system is important as well. Okay. Okay, we're going to start now on some of just the big pathways that you should be aware of that are important for travel the length of the central nervous system and important for diagnosis of neurological problems. We'll talk about brainstem anatomy because a lot of vascular accidents occur in the brainstem. Important to know the cranial nerves, not only the central components of the cranial nerves, but the peripherals as well. A little bit about some of the nuclei that are in the telencephalon, and then we'll talk about some of the lesions later on. Okay, there are three major pathways that travel all the way from the spinal cord to the cortex, or from cortex to spinal cord, and you should know these, okay? There are two sensory pathways. One is a pathway that carries pain and temperature. And this pathway, the important thing to remember about this pathway is, of course, where it is as it goes along, but the fact that when it comes in to the various levels of spinal cord, it crosses over immediately to the opposite side and then travels up through the brain, up to the spinal cord, the brain stem, all the way up to the cortex. Interruption of that pathway anywhere along there will give you a deficit in what we call general sensation, pain and temperature. The dorsal column system is a separate pathway that carries sensory information, primary proprioception and vibration, but also fine two-point discrimination. And this pathway, as you might suspect, travels in the dorsal columns or the posterior columns of the spinal cord. Okay? The entire posterior part of the spinal cord is devoted to this system, and it's a huge system. And when it enters the spinal cord, it ascends along on the ipsilateral side, but crosses over at the level of the medulla. Okay, so it crosses over, then ascends as a medial lemniscal system up through the brainstem into the sensory part of the thalamus, and eventually into the somatosensory cortex. So now we have, from my right side of the body here, we have my dorsal column system ascending on the lateral side of the spinal cord, my pain system ascending on the contralateral. So any damage to the spinal cord, a hemisection of the cord, is going to give me a sensory deficit on both sides of the cord, because I'll have, on one side, I'll have a sensory loss to the pain, and the other side to the dorsal columns. And we'll look at that here more in a minute. Okay, motor system, anytime you damage this long tract of motor fibers that come down from the cortex, here down through the posterior limb internal capsule, into the cerebral crus, through the pons, emerging as a medullary pyramid, then crossing over at the level of the medulla and spinal cord here, the decussation of the medullary pyramids, and well, eventually it'd be found as the lateral cortical spinal tract out here. This is one, this cell body here, the neuron comes all the way down, crosses over, and may extend way down into the sacral cord, so you can have basically an axon that's 3 foot long here, and it's supplied by many, many different arteries along the way. Any insult along the way will interrupt that, the information coming down there. So these 3 long systems here can be damaged anywhere in the cortex, in the brainstem, and in the spinal cord, and result in sensory deficits. And so you can see that damage can occur to these 3 systems quite easily with vascular insults to the vascular or traumatic insults to the central nervous system. So these 3 are important to know because often they're damaged in association with some other structures as well. Okay, in the spinal cord, this is showing you where these 3 systems lie here, and I have these 3 systems indicated by these red boxes, and you will get a copy of these slides at the termination of this course. So, as you remember, the fasciculus gracilis cuneatus here, the sensory fibers are found in a dorsal root ganglion out here. They come in and they ascend on the same side. So damage to this side of the cord is going to result in an ipsilateral deficit in touch and proprioception, discriminative touch and proprioception. The fibers from the pain system, which are found, it's called the anterolateral system because it's found in the anterolateral part of the cord. The fibers will also come in the dorsal root over here, but they will cross in this little structure right here called the anterior white commissure. And we'll see why that's important diagnostically after a bit. So they cross over. So the fibers that are carried in this cord here are part of the cord are from the contralateral body. Okay, so damage on this side of the spinal cord will give a ipsilateral deficit in touch and proprioception, a contralateral deficit in pain and temperature. The lateral cortical spinal tract here is indicated. These fibers have crossed over began in the contralateral cortex, cross over in the medullary pyramid, and will innervate lower motor neurons here in the ventral gray of the cord, which will go out and supply muscles. So damage here will cause, in this part of the cord, or degeneration as occurs in amyotrophic lateral sclerosis, where these fibers specifically degenerate, will result in an ipsilateral deficit. But as you can see, if the damage were up in the medulla or the midbrain, those fibers come down and cross over. So if we have damage in the brainstem or in the cortex, we will have a contralateral motor deficit or paralysis. Okay, there are a lot of other pathways in here, but it is damage to these 3 systems which are most evident when we have traumatic damage to the cord. You can get degeneration of these fibers here that carry information to the cerebellum and get cerebellar problems, but it is these 3 big, long pathways in the spinal cord that give us the largest symptomology. Okay, we also, although not so much anymore, but there was some, when I was a child anyway, there was a big outbreak of polio in the world. And polio specifically attacks these large anterior horn cells here, lower motor neurons, okay, that go out and supply the muscles. And that's why we had the paralysis associated with polio. And it's sort of started in a certain part of the cord and worked its way up. And if it didn't stop soon enough, people died because of respiratory failure when it got up into the cervical part of the cord. Okay, and this is something that you absolutely have to know. There will be several questions on licensing examinations that will basically use this information, where you have a difference between what we call an upper motor neuron lesion and a lower motor neuron lesion. Upper motor neuron lesion, or upper motor neurons, are any neurons up here that influence these lower motor neurons, okay? Primarily those associated with the cortical spinal system. The lower motor neurons are those neurons where you find the cell body in cranial nerve nuclei or in the ventral gray of the cord. They leave the central nervous system and go out and supply muscles or glands or sweat glands or secretomotor systems. So neurons that leave the central nervous system and go out are called lower motor neurons. You damage those, it's paralysis complete. You can damage these up here, and these neurons will still be alive here, and they will respond to local stimuli. So you can still, oh, I'm sorry. You can still have reflexes and tone in those muscles because these nerves are still alive, and they will respond to local signals such as reflexes, stretch reflexes. So when you have an upper motor neuron lesion up in the cortex or in the brain stem or even in the spinal cord where you damage the cortical spinal tract, the reflexes and tone are still present there because you have the afferent information, sensory information still coming in from the affected part of the body, and you can elicit reflexes and you still have tone. So the difference here is the type of paralysis you have. Okay, with upper motor neuron lesions, we call it spastic paralysis because we still have reflexes and tone. And this thing we call clonus, which is the reflex oscillations about a joint. And actually, because of the way the central nervous system is wired, which we really don't have time to go into here, we actually have brisk or hyperreflexia and increased tone in these individuals with a upper motor neuron lesion. We also have that extensor plantar reflex, which is present in newborns and in individuals that have this damage, or the Babinski response, where you stroke the sole of the foot and the toes will flare up, and loss of suprareflexes. The big difference, though, is the type of paralysis here. Here we have, with lower motor damage, where we have destroyed the neuron itself, we have the paralysis is called flaccid. There's no tone in the muscle. You can elicit no reflexes. And eventually, the muscle will become atrophic. It will atrophy. So this is a bit different in this individual. And if you is this working? Okay. If an individual comes into your office and his arm is completely limp, that's flaccid paralysis. Individuals that come in with a spastic paralysis will come in like this. Okay, the tone and reflexes are still there. This is typical of an upper motor neuron lesion. Okay, somebody that has damaged avulsion of the roots here in the arm, damage to the roots, the limb will be completely, and they'll come in and flop their arm up on the desk or something like that. Different than this, okay? It's a completely different syndrome. Okay, there are a number of other things, excuse me, that associated with damage to the spinal cord. Here, Tabes dorsalis. We're starting, at least in the United States, we're starting to see this again because of the increase in syphilis associated with some other environmental situations. But this is one which is typical, syphilis, where you lose proprioceptive input from the lower part of the body specifically. If you ask individuals to stand up and close their eyes, they can't maintain their balance because proprioception is a very important part of maintaining balance. So this is basically the dorsal columns will degenerate in tertiary syphilis. Brown-Séquard syndrome is basically usually a traumatic hemisection of the cord. And this is where you have ipsilateral paralysis below the level of the lesion, ipsilateral loss of proprioception, and contralateral loss of pain and temperature. Okay? And this one appears with regularity on the USMLE exams too. ALS is a autoimmune disease, and again, you should review that. It basically is degeneration of the long, heavily myelinated neurons in the cortical spinal tract, as opposed to multiple sclerosis, which can have a lot of different presentations. An anterior spinal artery infarct can occur sometimes with low blood pressure. Somebody's hemorrhaging, and we'll look at that here in just a second. Syringomyelia, this is an expansion or a tumor in what used to be the central canal of the spinal cord, and it has a very, very traditional appearance. Okay, so this is the cervical cord. This would be the part of the cord that would degenerate here in Tabes dorsalis, the dorsal columns. Okay? The anterior, in individuals that get an anterior spinal artery infarct, the anterior spinal artery basically supplies the anterior two-thirds of the cord. So the only thing that is preserved is the dorsal columns. So, and this typically happens in that area of the spinal cord where the reinforcement from the anterior spinal artery to the anterior spinal artery from medullary arteries is somewhat weak, and that is in the lower thoracic, upper lumbar part of the cord. So in that case, you would lose the cortical spinal fibers below that. So you'd have a paraplegic situation with loss of pain fibers as well below the level of the lesion. Okay, so cord lesions. Okay, in the brainstem, I put this in here because I really didn't know where else to put it up above. But know these for sure. You know, decebrate posturing or rigidity that occurs in individuals that have a brainstem lesion in the lower part of the midbrain, upper part of the pons. Okay, these individuals, you come into the room and touch them, and if they have a bilateral situation or a microphone here. These individuals have either a unilateral, bilateral situation, and you stimulate them with a decebrate rigidity, both the upper and lower extremities will be extended. And in some cases, if it's bad, the head will be back, the eyes will be back. That's not a good sign, okay? And it can be bilateral with a central bleed. but it can be unilateral as well. Somebody comes in with a stroke, they may show above the level of the red nucleus, okay, in the posterior limb internal capsule or in the cortex. They may show what we call a decorticate posturing. And if you stimulate, pinch them, they go. Put this on here. Good idea. Anyway, they have what we call a decorticate posturing, which is much like somebody with a upper motor neuron stroke, right? The upper limb will be flexed and the lower limb will still be extended. Okay, so decorticate and decerebrate posturing are important and are indicative of fairly serious lesions. And for some reason, the people that write the exams like you to know the difference between these, okay? And it has to do with the level of the red nucleus. If it's above the red nucleus in the midbrain, it's decorticate. If it's below the level of the red nucleus, it's decerebrate, okay? And that's usually how the question, what the information they want is really relative to where the lesion is, either higher or lower than the red nucleus. Just have a... Okay, so this is important to know. One of the other things that important to know in terms of, at least is helpful in terms of establishing where a lesion is if you have cranial nerve involvement. Okay, so you have to know where your cranial nerves are. We'll talk about the olfactory system briefly and the optic system. But it's these cranial nerves that are associated with the brainstem, midbrain, and below that are often involved in vascular lesions that are associated with the brainstem. So I've listed them here for you, and we'll talk about a few of them later on in the questions. One of the important things to remember, of course, is that, as we saw in that motor system here, that those motor fibers from the cortex that give us fine motor control, voluntary control, run along the ventral aspect of the brainstem, through the cerebral crus, through the ventral part of the pons. They emerge here as a medullary pyramids before they cross over at the junction of the spinal cord and medulla where it exits the skull. Okay, now you can see here those cerebellar tonsils I talked about earlier. If you have increased intracranial pressure and the foramen magnum is right here, this is part of the brain here that, I guess they're really here, right in this region, that is compressed and will compress the medulla. Compromising the blood supply and shutting down the respiratory and cardiovascular centers in the brainstem. Okay, so this might be a typical image on an exam, and this actually this arrow here points to the infarct. Now, can you tell me what part of the brainstem where that infarct is? Okay, so we recognize that this is a cerebellum here, and this is actually a fairly small part of the brainstem. So what would you guess this is? So this is the medulla. Okay, we can actually see one of the vertebral arteries here. The other vertebral artery is occluded, and it's giving rise to an infarct in the dorsal lateral part of the medulla. And actually, I think Dr. Tejasen talked about this lesion the first day posterior inferior cerebellar infarct here. This area here is the posterior lateral part of the medulla. This shows the various arteries that supply the anterior spinal arteries supplying the medial part of the medulla, and the pica, or posterior inferior cerebellar artery, supplying the lateral part. This is what that lesion looks like in the brain. Okay, and this is again a favorite question in all types of exams. So this is a pica. It's called Wallenberg syndrome of the lateral medulla, and this is one you absolutely should know for sure. Okay, and the key things, the thing about a lesion in the lower, or in the medulla and the lower part of the pons, is it's the only place where you can get this loss of pain and temperature on one side of the face, on the opposite side of the body. Okay, and that's diagnostic of pretty much where that is, because it's in that short part of the brainstem where the trigeminal fibers come in and descend before they cross over to supply the face. Okay, we have a problem here due to interruption of the fibers from the nucleus ambiguus and in 9, 10, and 11, cranial nerves 9, 10, 11 that supply the pharynx and the larynx. So we have hoarseness, difficulty in swallowing, cerebellar ataxia because of disruption of the fibers here in the superior cerebellar, or the inferior cerebellar peduncle. And then we have Horner syndrome, okay? Horner syndrome is due to, and we can have Horner syndromes due to damage in anywhere along its pathway of the sympathetic system, okay? But those fibers descend through the medulla. They're found right here next to those pain and temperature fibers that are ascending from the body, right in this region. So in this region here, then we have the pain fibers from the face, ipsilateral face, contralateral body, sympathetics here, and then we have the interruption of the fibers going to the cerebellum. In this region in here, we have that structure which you never could find. Remember the nucleus ambiguus? Okay, it lies right in this region too. And that is the outgoing supply for those striated muscles in the pharynx and larynx. Okay, so this is an important lesion, happens with a certain frequency, and it's something that you will probably see. The other places here, I put this slide in because you can get lesions in the cord that will give you a Horner syndrome. And Horner syndrome really is lack of sympathetic supply to one side of the face. Drooping of the eyelids, narrowing of the pupil, ptosis and meiosis. You also have anhidrosis, but you can't really see that, okay? But ptosis and meiosis, you can see that. You can get that with damage to the cord. You can get it here. Those fibers, remember, sympathetic fibers exit T1 through L2. They join the sympathetic chain, and then they're distributed throughout the body. Where else might we, for what other reason might we get a Horner syndrome? We could get it due to a tumor in the apex of the lung that right next to the sympathetic trunk here. You could have dissection of the carotid artery as due to an aneurysm here. Those fibers jump on the carotid artery, and the sympathetics are distributed along with the vascular system to the head. So you can have Horner syndrome due to damage in several different places. In the brainstem, spinal cord, thorax, and even in the neck. Okay, these are, when we talk about the cortical spinal system, the fibers that end in the cranial nerve nuclei are called the cortical bulbar. Bulb means brainstem. Okay, so those fibers, the motor fibers that we find in the brainstem go to these nuclei here, which have a somatomotor component. And we'll talk about lesions of some of these later on here in a few minutes. And I'm sure that you remember the facial nucleus. This is one of those which is invariably asked in licensing examinations. And the difference, ask you to distinguish the difference whether a specific type symptomology would be damage to the upper motor neuron or lower motor neuron. If you have a lower motor neuron lesion, the total side of the face is paralyzed. Bell's palsy, where you have a inflammation of the nerve, is a typical one there. Usually recovers from that. Upper motor neuron lesion, only the lower face. If only the lower face is paralyzed, you know it's an upper motor neuron lesion, okay? A lot of things here associated with cerebellar dysfunction. Don't have really time to review all of those. But remember how the cerebellum is organized. The midline is important for muscles along the spine. Individuals that have midline lesions in the vermis have truncal ataxia. It's difficult for them to even sit upright. Individuals that have damage to the paravermian section just next to the midline have ataxia, wide-bake gaze, because it's difficult for them to control the big muscles that attach the limbs to the body. Individuals with damage out in the lateral part of the hemispheres or the neocerebellum have things like intention tremor. They can walk fine, move their limbs fine, but they go try to do something, then they have the what we call neocerebellar signs. Okay. Damage to the part of the cerebellum, the floccular nodular lobe, that is intimately connected with the vestibular system, gives you nystagmus, vertigo, vomiting, that type of thing. So all these symptoms are pretty well associated with where the cerebellar deficit is. This is a whole nother lecture, right? The vestibular system. Important thing here to know is when individuals come in with neck injuries and you do caloric testing, how can you determine by which way the eyes go, how the eyes move in response to caloric testing in the ear, where the damage might be. The nice thing about caloric testing or looking at doll's eyes, that's how you can test almost the entire length of the brainstem with that type of testing. And you can't really do that, those doll's eye maneuvers, in somebody that comes in with a neck injury. So you need to know the caloric testing and the doll's eyes, because they're important in terms of acute care. There's a lot of other things here we don't have time to go through, but you need to go back and study that, okay? The hearing thing is important to know, although it's not particularly diagnostic, because once it gets much beyond the cochlear nuclei, the information goes up bilaterally. So most of what we have to deal with here is peripheral damage, acoustic neuromas, and then this loss of hearing in the ear. Okay, visual fields are very important, okay? And there's something here I put in here, some key things that just the way when the light comes in the eye and what happens at the cornea and lens, where you have a reversal of the visual fields, and the retinal fields, how the retinal fields are organized relative to the projections back to the cortex. Okay, a lot of what happens, though, in fact, most of what happens in the eye happens in the eye. Okay, most of visual problems, macular degeneration, diabetic retinopathies, all of these things happen right in the eye. So the majority of problems with visual problems are actually in the eye. But when you have damage to structures beyond the eye, then it's important that you're able to sort those out. And you have to examine, to really discern what's going on, you have to examine each eye separately, okay? This basic diagram is in every neurotext you'll ever see. And it gives you the basic types of visual field losses you get with damage to various parts of the optic projections. Anything that is between the eye and the optic chiasm will be only in that one eye, okay? If it's behind the chiasm, then you will have a visual field deficit because of what the fibers from the nasal retina cross over to the opposite side of the brain. So just like with our motor system, our sensory system, other sensory systems, what our left hemisphere has to deal with is the right side of the world, okay? Is the opposite side of the world. So light that comes in from the left finds its way to the right side of the brain, that information. So anything behind the optic chiasm will result in some deficit in the contralateral visual field. And these are all fairly straightforward, and these are the typical ones that you'll find that you need to work through, okay? We really don't have time to go through all of those, although I will have a question about them later that we'll test and see what the state of your knowledge is. But this right here is primarily what you need to focus on to understand the visual fields. It's one diagram. If you understand that and you understand what happens here at the lens when the light comes in, just like a camera, everything is reversed and inverted, okay, on the retina. Okay, I think this is, we'll talk about eye movements before we take a break. Okay, all of these eye movements are controlled by different parts of the brain. We talked about the vestibular ocular reflexes here. Those are things that are important for you to make diagnosis with chloric or doll's eyes testing. But the key thing to remember here, for every movement that you make, there's an equal and opposite movement of the eyes. This allows you to move your head and keep track of the world. All of these other movements here, rapid eye movements, smooth movements, vergence movements, these are all controlled by different parts of the brain, okay? And damage to those parts of the brain can interfere with those eye movements, obviously. Visual fixation is obviously not an eye movement, but it's that neurological mechanism that allows you to look at something and keep your eyes fixed on it. This is important because this part of the brain can be damaged, and it's in the occipital lobe, and you can't look at something and keep your eyes on it. As soon as you look at something, your eyes will drift off, okay? Okay, before we start this, why don't we take 5, okay? And we'll see you in 5 minutes.
Okay, welcome back after that brief break. As I said, we are trying to keep as on time as possible, and so we will continue with Dr. Norman. Thank you.
Okay, one of the things I just want to to mention about eye movements here is that the brain will not deal long-term with double vision. Okay, if you have a problem with one eye or particularly in children that are born with muscle problems in one eye, that needs to be fixed very soon, because if the brain cannot resolve the double vision, get back to where there's only one image, will completely ignore that eye eventually. So that you'll lose control of even moving the eye. So the brain will not only ignore the input from it, but it'll just ignore it completely. So it's something that needs to be dealt with. Okay, a couple of things here. You need to know the pupillary light reflexes and what those mean, and we'll have a couple of questions about that, but that's helpful to know that. There are some things here that I need to briefly talk about. This again is a question that sometimes appears in exams, and it's a bit of a mystery. We're not exactly sure why it occurs, but our eyes will accommodate, or the pupils will narrow when you shine light in it. You have pupillary light reflex. Okay, and that is lost in individuals with tertiary syphilis, called the Argyle-Robinson pupil. However, if you bring something close to the nose, the accommodation reflex is still there. That means that accommodation response is somewhere else in the brain besides where the pupillary light reflex is. And we don't really know for sure where that is, but this is a unique situation that occurs in this disease. This is a name for when you shine light into eye where you have damage for some reason in this eye here. Shine light, there's no response, but the direct response is absent, but the consensual response is still present. That's called a Marcus Gunn pupil. We haven't talked about the pathways, and we don't have time to do that, pathways that are involved in control of eye movements. But you remember the MLF, medial longitudinal fasciculus, that is very important for interconnecting all the interocular nuclei as well as the vestibular input in there. It's a big pathway that runs right in the center part of the brainstem. One important thing here, there are a couple of things here. This intranuclear ophthalmoplegia is that situation where somebody, when you're looking at eye movements, doing a neurological exam, ask them to look one way, both eyes move, ask them to look the other way, and one eye will stop at midline. One eye cannot adduct, okay? And that's diagnostic of what we call intranuclear ophthalmoplegia. And the basis is that the lateral gaze center controls horizontal conjugate gaze. And we have an interruption between the sixth nerve nucleus and the third nerve nucleus in that MLF, that eye, the ipsilateral eye cannot respond. Or the contralateral, if you're looking left, the right eye will not go past midline. And this is sometimes the first indication of multiple sclerosis, okay? And so this is something you should review and study. Olfactory system, couple things unique about it. One, it's the only sensory system that doesn't go through the thalamus. It has direct access to the cortex. Seizures in the temporal lobe can cause what we call uncle fits, or olfactory hallucinations that are usually unpleasant. Okay, seizures, damage to the uncus, the medial part of the temporal lobe. It's where the olfactory cortex is. This one here is appearing with more and more frequently. This was sort of discovered about 20 years ago. Excuse me. The olfactory neurons and GnRH neurons. You know what the GnRH neurons are? The neurons in the hypothalamus that direct the secretion of LH and FSH from the pituitary. Have you heard of those? Okay. Gonadotropin releasing hormone. Have you heard of that? Okay. These are hormones that are found, or not hormones, but neurons that are found in the arcuate nucleus, just up in the hypothalamus, that direct the pituitary. They produce GnRH to secrete LH and FSH. The olfactory neurons and the GnRH neurons start out in the nose, okay? And they migrate through into the optic tract all the way back to the hypothalamus, and very early on in embryology. And there's a genetic deficit that results in the malformation of proteins that are necessary, scaffolding proteins we call it, for that neuronal migration. And in that deficit, these individuals cannot smell, and they have what we call hypogonadotropic hypogonadism. If you give them the releasing factor, they can make LH and FSH, and the testes can work, or the ovaries can work. But this is a unique thing where you can't smell and you're infertile, and it's almost a diagnostic of this thing called Kallmann syndrome. That's a genetic deficit in the scaffolding proteins. And like I say, in the last few years, this has become more and more common on the examination, the licensing examinations, because it's sort of a unique situation that involves both the endocrine system and the olfactory system. Okay, a whole bunch of stuff here I'm not going to talk about. Okay, sleep, a lot of sleep disorders, seizures. There's a lot of neurological degenerative diseases. We talked about some of these demyelination diseases here that are important, that some of you have seen, and of course all the dementias. We just don't have time to talk all about those, but a lot of these will be on the exam, so you should review those. Okay, Dr. Paul Dofit will talk about some behavioral things, psychiatric diseases. There are also tumors in the central nervous system that are important. We're not going to talk about, like I say, Doctor, this will be covered tomorrow, some of these things. Okay, now you covered this briefly on the first day, okay? These alternating hemiplegias. And these basically are useful because anytime you have a cranial nerve deficit associated with a hemiplegia, it almost always tells you right where the lesion is, okay? And the three that are the most common, remember that cortical spinal tract, the upper motor neurons they are right on the surface here. They occupy the middle 2/3 of the cerebral cruise. And there are lesions that involve the third nerve and the motor system, and they travel right through the substance of the pons, sometimes involving the 6th nerve, and in the medulla, they involve the 12th nerve. If you have the 3rd nerve involved, if you have a 3rd nerve sign on one side, contralateral hemiplegia, that tells you it's in this side of the midbrain. If you have a 6th nerve palsy on the left, contralateral hemiplegia, it tells you it's in the pons. And if you have a lesion in the tongue and a contralateral hemiplegia, it tells you it's in this area here of the medulla. So those are important, and the terminology that Dr. Tejasen used was superior, middle, and inferior alternating hemiplegias. They also going to be called upper, middle, and lower hemiplegias, alternating hemiplegia. The alternating means that you have a cranial nerve sign on one side and a body sign on the opposite side. Okay, first question. A 39-year-old woman complains of persistent headache. MRA shows an aneurysm in the interpeduncular fossa. Okay, you should know what interpeduncular fossa is. Arising from the basilar tip. Which of the following cranial nerves would most likely be affected by this aneurysm? A is abducens, B oculomotor, C optic, D trigeminal, E trochlear. Okay, vote. Very good. So the oculomotor nerve, the basilar tip here is right here where it divides into the superior cerebellar and the posterior cerebral arteries. And the 3rd nerve invariably comes out between those two arteries. But if you get a big aneurysm right here, the nerve that is most likely to be compromised is that oculomotor nerve. Okay. This is a question that there are sometimes questions that are asked that really all they're asking is whether you know your anatomy. Okay? And this is one of those questions. But it's sort of phrased in a vignette. The MRI of a 60-year-old painter shows a large AV malformation between the lenticular nucleus and the dorsal thalamus. Based on this location, this AVM would most likely affect which of the following structures? Anterior limb of the internal capsule, crus cerebri, external capsule, posterior limb of the internal capsule, retrolenticular limb of the internal capsule. Okay, vote. Okay, very good. You know your anatomy. This shows that the slide here okay, this one slide here. Really what I want to show you here is just remember the internal capsule is named based on its association with the lenticular nucleus and other structures. So we have lenticulocaudate portion, lenticulothalamic portion, okay? And sometimes those terms are used in exams as well. Okay, a 48-year-old obese and hypertensive man was brought to the emergency room after experiencing sudden onset of weakness of his upper and lower left extremities. CT shows an infarcted area of the medulla. damage to which of the following tracts or fiber bundles of the medulla would most likely explain this deficit? Anterior lateral system, medial meniscus, cortical spinal fibers, rubospinal fibers, vestibulospinal fibers. Okay, vote. I'm hoping for 100% on this. Almost. Yes, right. Of course, cortical spinal fibers is the correct answer. This is the only place in the brain where the cortical spinal, the motor system, is entirely by itself. And you can actually get a lesion of that medullary pyramid there and actually get a little bit different symptomology you would anywhere else in the brain because it's all by itself. There's no other fibers or not, things affected, associated there. Okay. And this shows the type of infarct that you might get. This shows, and this again shows the medulla here in a different type of imaging, but it shows that medullary infarct, medial medullary infarct here. Now, if like in our country, you probably learned neuroscience with dorsal up, but all the imaging is with the ventral part of the central nervous system up, okay? The way we teach it is, for some reason, it was before imaging, but everybody teaches most of the time with this side up here when we're teaching about the spinal cord, the brain stem. But, so you have to make sure you can recognize this. Can you tell me what artery might be involved, specifically what artery might be involved in that lesion? What artery is that? The anterior spinal artery. Okay. The anterior spinal artery arises from this artery here, the vertebral. Here's that posterior inferior cerebellar artery. The anterior spinal artery actually supplies most of the ventral part of the medulla. And it's more typically that artery that is infarcted when we have that type of lesion there. Okay, a 72-year-old man with a history of hypertension and hypercholesterolemia had an episode of diplopia, gait unsteadiness with staggering to the right and right-handed weakness. I think there's another. Okay, these are the key signs and symptoms. Diagonal double vision and left eye movements with only 1 millimeter elevation, 2 millimeter adduction, and 3 millimeter depression. Normal abduction and leftosis. Okay. There was right and left arm. So what do we think this is? What nerve? So we have superior rectus is not working, medial rectus is not working, inferior rectus is not working, but the lateral rectus is. So, okay. So this is a key part of it right here, okay? We also have equivocal right plantar response, unsteady gait, right hand clumsiness, unsteady gait. What does that bring to mind? What part of the brain? Wide base gait, ataxia. Okay, so we have a third nerve palsy with cerebellar signs, right? Well, where's the lesion? Has to be one place, right? It has to be in the midbrain, right where the third nerve is. And what is there that is associated with the cerebellum that would give you the cerebellar signs? Okay. This is the midbrain, okay? This shows you that lesion. And there's some extension into here, the cerebral crus where the cortical spinal fibers are. Remember the red nucleus? It's in that fiber pathway that starts in the cerebellum, outflow up to the red nucleus, up to the cortex. It's the outflow of the cerebellum that coordinates the muscle activity, okay? So if you interrupt that fibers that go through that red nucleus, that fiber tract, that dentato from the dentate nucleus, rubro-thalamic pathway, they're going to have cerebellar signs, okay? But the third nerve nucleus, if the question was, where is the lesion? It's in the midbrain because it's the third nerve. So that's kind of a key to where things are, is when we have involvement of a cranial nerve. Okay, the medial part of the midbrain. Okay, a 14-year-old boy with signs of increased intracranial pressure, stupor, vomiting, headache is referred to a neurologist. The examination reveals a paralysis, upward gaze, and MRI shows a large tumor of the pineal gland. Pressure on which of the following structures would most specifically be related to the gaze deficit? Superior colliculus, extratrochlear nerve, posterior commissure, inferior colliculus, lateral geniculate nucleus. Okay, vote please. Well, more got it right. I guess that's pretty good. 3%, that's pretty good. Now here, this is a typical one. This is almost always on the exam, okay? This is actually a normal brain here in the area we're talking about, okay? So this is the superior, that's a cerebral aqueduct, so we know that's the midbrain. You see that whole midbrain. We have the pineal gland here. We have parts of the thalamus. This section shows part of the pons because remember, the brainstem is like this. And when we take a section through the cortex, a coronal section, we're going to cut almost vertically through the brainstem. Anyway, this is a pineal gland here. It sits right above the rostral part of the midbrain, right over the superior colliculus. The vertical gaze center is in the superior colliculus pretectal area, okay? This next slide, this actually shows, see the difference here? This is actually a pineal tumor. And you can see how that might compress that and actually can compromise blood flow, or not blood flow, but CSF flow through the cerebral aqueduct and cause hydrocephalus as well. But that's a good example, which we actually found in our neuroanatomy lab of a pineal tumor. Okay. Next question. An 80-year-old woman is brought to the emergency room by her adult grandson. He explained that during dinner she slumped off her chair, did not lose consciousness, but had trouble speaking. The examination reveals weakness of the upper and lower extremities on the left and deviation of the tongue to the right on protrusion. Which of the following is the most likely location of the lesion in this elderly patient? Medial basilar pons on the right, medial basilar pons on the left, medial medulla on the right, medial medulla on the left, medial midbrain on the right. I'll give you just a second to think about this. Okay, vote. Okay, that's good. I think I have, again, just a picture showing here that the nucleus for the 12th nerve, the hypoglossal, comes down, exits right between the inferior olive here and the medulla. And so we're going to get that, and the cortical spinal tract as well. So that's a typical one of those alternating plegia, which is the inferior alternating amplesia because it involves the 12th nerve. And again, the 12th nerve is the involvement of the 12th nerve is the key point to where the lesion actually is. A 78-year-old active woman experiences sudden weakness of right upper extremity during angiogram to determine the patency of her carotid bifurcation. The immediate examination reveals weakness on both extremities on the right and a partial loss of vision in both eyes. Okay, so in both eyes, partial loss in both eyes. Okay? These observations suggest an embolic stroke resulting in lesion involving motor and visual structures. The infarcted area in a CT points to the occlusion of one vessel. Which of the following vessels is most likely occluded? Anterior cerebral, anterior choroidal artery, ophthalmic artery, lateral posterior choroidal artery, posterior cerebral artery. This is actually a pretty hard question. Shall I say vote or guess? Hey. Okay. Here we have a posterior cerebral artery. Okay. You know where they put that would be hard to explain. Okay. This question is the answer is the anterior choroidal artery. And I guess that, you know, most people don't study where the anterior choroidal artery is, but it's one of the first arteries that comes off the internal carotid artery. Goes right back, and actually in the temporal lobe, it's responsible for forming the choroid plexus. Okay? And as it goes right by as it goes by comes right by here, it goes by the optic tract and the cerebral crus. It supplies part of that optic tract and the cerebral crus, which are right together. Okay? And the reason I put this in is, I don't know about the USMLE test, but the test that we give our students at the end of the course in neuroscience is a board exam, a national board exam, and this question has been on that for the last 2 times. So I know it's going to appear on the USMLE here pretty quick. But this is the posterior limb of the internal caps or the cerebral crus, they're right there together with the anterior choroidal artery. If you look it up in your textbook, a good anatomy textbook, it'll show that relationship. Okay, you should all get this one, okay? A 60-year-old man complains to his family physician of severe headaches. The examination reveals visual field deficits in both eyes, and an MRI shows a lesion in the cerebral cortex. Which of the following cortical structures represents the most likely location of this lesion? Now, these are terms probably some of you haven't seen for a while, right? Angular gyrus, do you remember where that is? Cingulate gyrus, lingual gyrus, parahippocampal gyrus, and the orbital gyrus. Okay, vote. Oh my God. Okay. Orbital gyrus. Visual field deficit in both eyes. Okay. But it has to be behind what structure? Has to be caudal to the optic chiasm. Okay? Has to be behind the optic chiasm. Okay, and where is the visual cortex? Optic cortex. Right here, right? Occipital lobe. We have above the calcarine fissure, we have the cuneus, below we have the lingula, right? So you can have posterior cerebral artery infarcts that involve one side, one quadrant, because we have sort of separated by force back here in the occipital cortex. But the occipital cortex is big, and above it, the cuneus lobe and the lingula are the two parts of the occipital cortex. Okay? Okay. A 76-year-old man presents with a resting tremor, bradykinesia, and stoop posture. Okay, you've seen that, right? These symptoms, you know what? Bradykinesia is poverty of movement, okay? Very little movement. These symptoms suggest loss of a prominent population of cells in the brain. Which of the following structures is the most likely affected by this patient? Resting tremor, okay? Poverty of movement and a stoop posture. Okay? You all can put a name to this, right? Where is the deficit? Lateral cerebellar, locus coeruleus, red nucleus, substantia nigra, subthalamic nucleus. Please vote. Yay. Good. So dopamine, almost all the dopamine in the brain comes from the midbrain, from the ventral tegmental area just below the substantia nigra, from the substantia nigra. Parkinson's disease is a classic one that will appear in one form or the other. And actually, resting tremor is not the biggest, the most debilitating part of it. The most debilitating part of it is the inability to move because of the increased tone in both the flexors and the extensors. So it's very hard to move, very hard to initiate movement. Okay, a 34-year-old homemakers referred to your endocrine service because of amenorrhea for several months, after several months of irregular menstrual cycles. Your clinical evaluation reveals that she has low gonadotropin and estrogen levels and elevated serum prolactin. A neurological examination shows that she has a temporal visual field deficit in both eyes. The most likely cause of these symptoms is A, pituitary tumor, B, herniation of temporal lobe, C, left temporal lobe tumor, D, left temporal lobe seizure. Okay, vote please. Very good. I don't have to explain that one then. Anytime you have this temporal field loss in both eyes, you know it has to impact the optic chiasm. Okay, so this is a image of the the head and part of the brain, and we see this typical structure here has everything labeled for you. Basilar artery, infarct and lateral caudal pons, shows where the infarct is here. The vascular lesion in this area would most likely involve the anterior spinal artery, anterior inferior cerebellar artery, superior cerebellar artery, posterior cerebral artery, posterior inferior cerebellar artery. This is one, just classically, you just have to know your vasculature. Please vote. Okay, the answer is is the anterior inferior cerebellar artery. If we were, this is in the pons. If we were in the medulla, it would be the posterior inferior cerebellar. If we're in the pons, it's the anterior inferior cerebellar, and it's basically in the same part of the brain stem. It's just anterior to the posterior inferior cerebellar. And this one will give you a symptomology very similar to the pica, except it won't involve they won't have the horse, let's see, what is it you have here? Here you have involvement of the seventh nerve here, okay? Along with all the other things that we saw in the posterior inferior cerebellar artery, you have involvement you'll have a facial paralysis because where the seventh nerve exits here. Okay. A 48-year-old woman presents in the emergency room with flailing, involuntary movements of her right upper extremity. She reports that the symptoms occurred suddenly. CT scan indicated a lesion in the forebrain. Where is the most likely site of the lesion? The left striatum, left subthalamic nucleus, right premotor cortex, right substantia nigra. Okay, please vote. Okay, this is very this is a very typical lesion, and it's called hemiballismus, hemiballism. Okay, so it's subthalamic nucleus. Very, very typical for this lesion. In the striatum, when we get damage to the striatum, more often than not, we get coriform movements, the jerky, like Huntington's chorea. Or if it's the caudate and putamen only, then we get the athetosis, the sinuous type movement, like the dancers the other night. Okay, so left subflammation, this is very typical of the of damage to that structure. Okay, during attempting, you should, I think you should all get this one because of what you did on the other one here. So, during attempted theft, a man is shot in the head and the bullet destroys his pituitary stalk. He is transported to the hospital and managed to survive. However, he's informed that his hormone balance will likely be abnormal as a result of his injury. Which of the following hormones would be expected to be secreted in excess after damage to the pituitary stalk? Cortisol, aldosterone, testosterone, thyroxine, or prolactin? Please vote. Okay, prolactin. The key here is that all of the hormones in the pituitary, growth hormone, ACTH, LH, FSH, I guess that's the only ones I can think of anyway, all but one, prolactin, are under stimulatory control. Prolactin is under inhibitory control from the brain. So if you release the control from the brain, prolactin will go up, okay? Okay, Jack is an 18-year-old patient who is referred to a neurologist. He complains of muscle weakness, fatigue, respiratory difficulties. His neurologist used various clinical tests and find out the patient is suffering from classical myasthenia gravis. The symptoms of this disorder are usually caused by the presence and actions of one of the following circulating antibodies in the plasma. Antibodies against the calcium channels at the neuromuscular junction, antibodies directed against choline acetyltransferase, antibodies directed against nicotinic acetylcholine receptors at the neuromuscular junction, antibodies directed against muscarinic receptors, antibodies directed against acetylcholinesterase at the neuromuscular junction. Please vote. Very good, but you can see that that's bold. I had the answer on the slide. So it's against myasthenia gravis is degeneration of basically the neuromuscular junction, and basically it's an autoimmune disease against these acetylcholine receptors. Okay, I couldn't make this bigger. A 65-year-old man is being evaluated because his speech has been noted to lack appropriate fluency. Throughout the evaluation, the patient has trouble finding certain words, but seems to understand everything asked of him. His ability to repeat is poor, but is preserved better than his ability to generate spontaneous responses to posed questions. When he responds to questions, he frequently uses the wrong word. The clinical findings are most consistent with the following types of aphasia. A is Broca, C conduction, C global, D thalamic, E transcortical motor, F transcortical sensory, or G Wernicke's. Please vote. Okay, that's good. Expressive aphasias are generally in Broca's areas, receptive aphasias, and Wernicke's area. One of the things I read the other day that people who lose the ability to speak all the time from strokes in this area still maintain the ability to use bad language, swear words, and they think that that is part of that ability is located in the striatum, actually. Have you heard of Tourette's syndrome? Where people have tics, motor tics, and sometimes language expression associated with the tics. And almost always the language is bad language. And that we know Tourette's syndrome is in the striatum, and the association there with the vocalization, along with the preservation of that ability in people who have Broca's areas of damage. It may be that we have language areas in places we had not thought before. Okay, a 2-week-old baby girl is brought to the pediatrician for her first doctor appointment. On examination, the baby is found to have a tuft of hair on her lower back, but no lesion is found. Ultrasound shows no herniation of any kind. Which of the following conditions does this baby have? Okay, anencephaly, meningeal seal, meningeal myocele, spina bifida cystica, spina bifida occulta. Please vote.
Give you 10 more minutes.
I'm finished.
Huh?
Okay, this is that neural tube deficit thing. You can have deficits all the way to where you have kiddos with their spinal cord hanging out, but this is the least of what you might get. But it is where that anterior or that posterior neural pore doesn't quite close completely, and we get a little symptom from there. I think that is all. You did very well.
Dr. Norman, thank you. He caught me unawares. We have a few minutes before lunch, so I would like to know if there's any questions and answers from the audience. Where's the mic?
Any volunteer? That'd be that. The speaker wants to know that how much you can absorb.
If you want to go to the United States and study, then you're going to have to express yourself and get a bit out of your shell. All right. Who has a question for Dr. Norman? Well, anything? Okay, anything.
Sure.
And actually, Dr. Bill is back there in the back, and he'd be happy to field a question as well. All right, so please, pick one. Okay. I'll walk down here. All right.
Uh-oh. Now you're in trouble.
Sir? Do you have a question? No. Okay. Well, make one up. Remember, last night when we did the interviewing, you will be asked questions, and you will be asked if you have questions. So it would be good to be prepared with both. All right. Who? Come on, folks. I wonder if this young lady has a question. No? Okay. All right, Sam kid.
ขอถามหน่อย
I'm having trouble here.
เข้าใจได้กี่เปอร์เซ็นต์ 40% ยกมือสิ 40% ที่เลคเชอร์มาทั้งหมดเนี่ย you understand 40% of his talk more 50% raise your hand
Raise your hand.
60%, 70%. Okay, in here, I know one is a neuroradiologist. What do you think? Go ahead. Pick her.
You know that.
She's
Thank you for your lecture. So about the knowledge that he gave us is very interesting for our study. In my idea, it's very great, and I can understood everything you say because do it every day, and I have so it's very clear for me. Thank you for your knowledge.
Any pediatric neurologist in the audience? มีใครบ้าง pediatric radiologist? Go ahead. Huh? Okay, neurologist. Okay, next. Pick this one.
Who's this one?
Neurologist.
This part is difficult because most of you don't use it. My wife is a pulmonologist, and she has to ask me all the time, well, what is this? You know, because she doesn't remember, she doesn't use it very much. So if you're going to take the examination, this is an area, and it's not a huge area of the examination, but you need to know sort of the basic fundamentals, and that's what we tried to cover today.
Yeah, thank you for your lecture. Actually, I would like you to advise us which modalities, such as from internet website, which one is the best for us to review or to prepare to do the examinations?
Well, I don't know about the website. The websites, I don't generally use those myself, but the best thing I can do is give you the same advice that Dr. Tanner did, is you know, take the test online and take it 2 or 3 times. Just keep going back until you get familiar with it and you can answer those questions, because they change, and read through. You have the books, right? The USMLE books. You have access to those here, or right, you have in the library or wherever. But those are good too, to show you just the type of questions. Some of the times the questions are asked in different ways. Sometimes they ask from the point of view of the anatomy, sometimes from the symptomology, sometimes from the structure, sometimes from the vascular system. So you have to be familiar with the different ways. But after, I think tomorrow, after you hear the speaker that gives you the stuff on some of the psychiatry and the behavioral stuff, you'll have a better idea too of the breadth of things you'll have to know.
Okay, my advice to you พูดภาษาไทยก็ได้ material ที่ผมเอามาเนี่ยหนังสือ35 เล่ม you don't need to go look at the internet won't give you access to the textbook 35 เล่มนะทุกฟิล step 1 CD 10 เล่มมั้ง step 2 10 กว่าเล่ม step 3 10 กว่าเล่ม แล้วมี miscellaneous topic ของ behavioral science with pharmaco ทุกอย่างคุณทั้งหลายใช้ Adobe 7 หรือ 8 มีเปล่า Adobe Reader ได้ it scan in digital form อยู่กับ Adobe Reader มันเป็นเล่มใช่ไหมเพราะฉะนั้นผมเห็นบางคนก็ถือ Kaplan Q Book ก็อย่างที่ผมพูดตั้งแต่แรกว่ายูจะต้องตั้งเป็นทีมไป study กันใช่ไหม week นี้ study neuro week หน้า study pharmaco แต่ควรจะสอบ basic science ก่อนใช่ไหม basic science ก็เนี่ยที่กำลังรีวิวเนี่ยยูก็เป็น pharmaco biochemistry molecular ถ้าไม่พร้อมอย่าสอบเมื่อวานมีใครมาคุยผมรีบร้อนครับผมสอบได้82 forget it your application will be throw away so why spend money take exam when you take it 99% don't take it below 95 คนไทยบอกโอ้โหเพราะงั้นอย่าไปดีกว่าแต่คุณมีความรู้มีสมอง มีแมทเทียลมาให้อ่านแล้วถ้าไม่มานั่งฟังไม่เอากลับไปศึกษา you ไม่มี opportunity ขอพูดอีกทีเดียวเหมือนบัวในสระเคยได้ยินไหมบัวใต้น้ำบัวผิวน้ำบัวเหนือน้ำไม่บานกับบัวเหนือน้ำบานตอนนี้ผมเอาวิทยาทานเชิญสปีกเกอร์มาเอาหนังสือมาถวายให้ท่าน What do you want you need to study ก็เหมือนการศึกษาศาสนาพุทธก็ไปเข้าฌานเพื่อจะได้ไม่เราไม่ต้องการให้คุณปรินิพพานหรอกขอให้ you achieve it's a key and a ticket for you to go you have the example and the next speaker this afternoon she trained for Mayo Clinic she internal medicine here she's an endocrine trained in Mayo Clinic you can ask her to how to get to Mayo Clinic like me I train pediatric cardiology okay one more question come on don't be fat คือนิสัยคนไทยเนี่ยเวลาอยู่ไปแข่งกับแขกกับฝรั่งเนี่ยหรือฟิลิปปินส์เนี่ย don't do that stand up express yourself speak up ผมไปใหม่ๆผมก็ทำอย่างเงี้ย
What did you want to do at this point? Just go ahead and break for lunch. Okay. Oh, sure.
Thanks.
So you're going to break them for lunch?
Right, and I'll have announcements and break them for lunch. Okay. All right. Excuse me, before we break for lunch, I have several announcements actually. First, please, before you go to lunch, now today we have to return